Hi friends, so we continue our discussion on the final lap surgery for your Neet PG exams. In this video, we shall be discussing your previous year questions of 2021 and 2022 from your endocrine section. So we have the first question over here, which is a patient underwent surgery for breast carcinoma around 4 months back, now is presenting with a painless swelling over the arm. Image is given as below. What is your diagnosis? So this was a straightforward question where your answer was the lymphedema, right? So if you look over here, the patient has undergone your left-sided mastectomy and is presenting with your left arm swelling, which is your lymphedema. Now, most of the candidates who had given you the exam had confused this with your lymphangiosarcoma. So please remember, lymphangiosarcoma or your Stewart-Travis syndrome usually occurs your post-mastectomy in the affected arm after a duration of your 10 years. Right, so a minimum duration of 10 years is required for a lymphangiosarcoma to develop, and this would be somewhat an image of your lymphangiosarcoma. Another important point with respect to this topic is regarding your venous thrombosis, right? So venous thrombosis, which is also your Pyqs disease, right? So this is your axillary vein thrombosis, right? It occurs between your first rib and your clavicle, right? So these are your few important points with respect to this question. Now the next question that was again asked from your breast was your regarding your Purdy orange. Which of the following is your correct statement, right? And an interesting part of this question is that it was again repeated in a similar fashion in your recently conducted FMG exam by the NAT board. So please be prepared for this repeat questions. So the answer over here is again a very straightforward, which is your involvement of your subdermal lymphatics. Right, now if you look at the image of your Purdy orange, so this is your image of your Purdy orange, which looks like a peel of orange. And please remember, your Purdy orange would come under your stage T4B. Now moving down to the next question, the incorrect statement regarding your pheochromocytoma. Please remember that pheochromocytoma is an invariably favorite topic of the examiners, so please do not forget to revise it before your exams. Now options given were diagnosis by urine VMA and catecholamines, surgical excision, propranolol given initially, can present as hypertension alone and sometimes with vomiting and pain abdomen. Yes, the answer is your propranolol given initially. Please remember, beta blockers are never ever given initially. It's always alpha blockers followed by your beta blockers. So let's take a look at some of the important points from your pheochromocytoma. These are your neuroectodermal tissue of your adrenal medulla. So these are your tumors of your adrenal medulla. Now what are your paragangliomas? These are your extra-adrenal parasympathetic and sympathetic ganglia, right? The important word is this, extra-adrenal. Then around 90% of your patient presents with your headache, palpitation and sweating. The most common symptom is your hypertension, present in around 80 to 90% of the patient. It is usually paroxysmal and it may be continuous in around 30%. Headache is present around 60 to 90, followed by sweating, which is 50 to 70, and palpitation, which is 50 to 70%. Now this particular table values have been absolutely taken from your recent edition of your Bailey and Love, so you can mark the answer on the basis of the incidence given, right? Then the investigation of choice for your pheochromocytoma is your urine 24-hour free metanephrines. And if they ask you regarding the radiological investigation of your choice, then that is your MRI. Now regarding your pre-op conditioning, it's always alpha blockers followed by beta blockers. Why never beta blockers are given first? Because it will lead to your unopposed action of your alpha adrenergic receptors, and your treatment of choice remains your lap or open adrenalectomy, right? So Please remember this important points with respect to your pheochromocytoma, and the answer over here in your Neet 2021 question would have been your propranolol given initially. Now moving down to the next question. So we have it from the thyroid section. So a female presents to you with the neck swelling and later develops your cervical node enlargement. HP image is given as below, right? I think the statement over here is missing. We need to identify the incorrect statement, right? The incorrect statement. So nuclear characteristics for identification. Better prognosis is associated with the condition. FNAC is not diagnosed. Spread quickly via lymphatics. So the first step over here is to identify the HP image. So from the HP image, what do you think it is? Yes, it is a image of your papillary thyroid cancer. So if you look over here, the cells over here have a particular nuclear characteristics, right? Like an orphan Annie nuclei. So yes, this is a true statement where nuclear characteristics are used for identification. They are used for a better prognosis, which are associated with this. FNAC is not diagnostic. This is a false statement. Now this is true in case of your follicular adenoma and carcinoma, right, where you would require an HPE. But in case of papillary carcinoma, your FNAC is diagnostic and it spread quickly via lymphatics is again a true statement. Hence we see your cervical node enlargement, right? So the answer over here would have been C. And this thyroid carcinoma is a very important topic. So let's take a look at the few important one-liners from your thyroid carcinoma. So papillary carcinoma, they are your more common in female. Peak incidence in your 3rd to 5th decade. Had a propensity for the lymph node. Hence in your given question was regarding your cervical lymph node enlargement. Distant mets is uncommon unlike your follicular carcinoma. They have a high rate of occult metastasis. The cutoff for your papillary microcarcinoma is your less than 1 centimeter. Then it has excellent prognosis, and you have your complex branching papillae, which are your HP image with pseudo inclusion, nuclear grooving and psammoma border. So these are your images, HP images of your papillary carcinoma, right? And if you look at the image that was given, your orphan Annie nuclei, close facet nuclei and your open facet nuclei. So these are your characteristics finding which is going to help you to diagnose your papillary thyroid carcinoma, right? Now moving down to your follicular carcinoma, it is usually seen in elderly. It is differentiated only on your histopath, right? So the question that was asked, FNAC is not diagnostic, that is true for your follicular carcinoma. Now it has propensity for your blood-borne metastasis. It is associated with your history of long-standing goiter, and they have an Hurtle cell variant which has a poor prognosis and presence of your oxyphilic cells. Then we have your anaplastic thyroid carcinoma, where you have your dedifferentiation of your papillary or poorly differentiated carcinoma. They have your rapid growth, visceral invasion and your distant mets. Then they have an HP, your giant and multinucleate cell. They have sheets of cell marked with your heterogeneity, and there is a limited role of your radiotherapy and your chemotherapy, and tracheostomy is done on presence of airway signs of obstruction. Then your next type of thyroid carcinoma is the medullary thyroid carcinoma. So few important points of your medullary thyroid carcinoma arise from your parafollicular cells. A myeloid stroma on your HP is one of the characteristics. Then we have your calcitonin and CE elevated. Now this calcitonin is also used in the post-operative as a marker of your recurrence. Then we have your diarrhea in around 30%, and the responsible hormone is your 5-hydroxytryptamine. then it may be familial in 10 to 20% and it is associated with your MEN syndrome. So the first series of our final lap surgery has a detailed discussion about your MEN syndrome, and also a detailed discussion of your MEN syndrome is available in form of your MEN syndrome videos in our YouTube channel, which you can check out, right? And it has a lymph node propensity of around 50 to 60%, and the treatment would be your bilateral neck dissection along with your total thyroidectomy. So these were the few important points with respect to your thyroid carcinoma. So now moving down to the next question. So we have these two questions which were repeated from the same particular topic, which was your complications of thyroidectomy. So we had this first question that was asked in your Neet 2021. A patient underwent a surgery which was your thyroidectomy. Post the surgery, the anesthetist was unable to extubate her due to persistent cyanosis and airway obstruction. What is your cause? And then we have your next question that was again asked from the same topic in your Neet 2022, which is a 40-year-old female patient presents underwent thyroidectomy and 3 days after developed perioral numbness. Which of the following investigation needs to be done? So they were from the common topic, which was the complications of your thyroidectomy. So let's take a look at the discussion of your complications of thyroidectomy, then we shall come back to these questions. So the complications of your thyroidectomy, first is your injury to parathyroid. Now it is usually manifest after 3 to 5 days. Now it may present with a tingling sensation or a twitching, or with the low levels of calcium. So if there are low levels of calcium, there might be circumoral numbness, digital numbness, and two important signs which are associated with low calcium level are your Schwartz's sign and your Troche sign, right? Then we have your nerve injury. So the nerve injury could be your superior laryngeal nerve injury. Now if it is a superior laryngeal nerve injury, there would be loss of timbre of voice. Please remember, in your exam, the clinical scenarios regarding your SLN would be mainly linked to your singers, because over there they would be having a loss of timbre of voice or the loss of pitch of voice. Then we have your recurrent laryngeal nerve. Then over here, if it is a unilateral, there would be hoarseness of voice, and in case of bilateral, there would be distress, cyanosis, and your vocal cord palsy, right? So if we come back to the we shall come back to the question later on. First, let's discuss the another important complication, which is your hemorrhage. So it is the most frequent life threatening complication. It could be primary, that is occurring immediately during surgery. Secondary. Now what happens in secondary? It occurs 7 to 10 days after surgery, right? Usually due to a secondary infection. Then you have your reactionary, which occurred within 24 hours of surgery. And then we have your primary, which is occurring during your surgery. So please remember your primary, secondary, and reactionary hemorrhage. Now another important clinical scenario that is asked from your this complications of thyroidectomy is, what will you do if your hematoma develops during your evening rounds? The questions are framed like you are you are a resident on the evening round attending a patient of a post thyroidectomy, and you find that a hematoma is developed around the suture site. So please remember that you will immediately open the suture or clips, right? So this is your first immediate step on seeing your hematoma, and then obviously you would ask for your help from your senior postgraduate trainees and your senior resident doctors. So coming back to the question over here, the first question which was asking, unable to extubate her due to persistent cyanosis and airway obstruction. So your answer would have been your bilateral recurrent nerve injury. Now your next question, which was asking your developed perioral numbness, which of the following investigation needs to be done? So over here it is your hypocalcemia. Now this hypocalcemia basically due to the injury of your parathyroid glands. So what would you be needing to do is your calcium phosphate and your PTH scan. So this were the few questions, and there was one more question which was regarding a component of Men2B syndrome, all except. The answer is your parathyroid adenoma. We have discussed this in our first session. Since you guys had requested to have it congruent in form of your topic wise, hence I have just added this question over here. The answer of Men2 syndrome not included is your parathyroid adenoma. Those who want to look at the explanation may take a look back at the first video of this session. So this was all about the questions from your endocrine section. So as you could see, the questions were straightforward and high scoring. So please do revise these important topics and do not make mistakes in this. So keep revising. All the best for your exams. Thank you.